In Part 1, I made the case that cost is the master variable in American healthcare. I diagnosed what I called a regulated cartel, a system where government rules have suppressed the supply of healthcare while private actors have extracted unearned profits that no other system allows. I also further explained why single payer isn't a viable path for us. It requires a level of government control and a set of quality of care trade-offs that Americans have consistently rejected. If you haven't heard Part 1, I'd recommend going back to it. If you have, let's get to the reform program. There are several parts to it, but before I get into details, I want to give you the principle that ties them together. Because the principle is what makes this different from both the standard left and standard right approaches to healthcare. Here it is. Where private concentrated interests have killed competition, government breaks their grip. Where government itself killed competition, it gets out of the way. In other words, use price discipline where there is no market. Use supply expansion where there is. Let me explain why that distinction matters. When the government caps prices in a competitive market, bad things happen. Suppliers leave, quality drops, shortages develop, capital flees. The standard right-wing critique of price controls is correct in competitive markets. But healthcare has segments that are not competitive. When one system owns every hospital in a region, that is not a market. That is a monopoly. When 3 drug middlemen control 80% of all prescriptions, that is not a market. That is an oligopoly. When a drug is under patent and there are no substitutes, that is not a market. That is a temporary monopoly granted by the government. In these cases, the standard left-wing argument for government action is correct. That principle ties the whole reform program together. Here's how it applies in practice. There are 5 specific levers. Lever 1, drug pricing. The government, through Medicare and Medicaid, is by far the largest buyer of prescription drugs in this country. Until very recently, federal law prohibited Medicare from negotiating drug prices. We bought drugs at whatever price the drug companies set. Other countries, Germany, France, Canada, Switzerland, all negotiate drug prices through their national health systems. They pay a fraction of what we pay for the same drugs, from the same companies. The Inflation Reduction Act in 2022 finally allowed Medicare to negotiate a small list of drug prices. That should be expanded significantly to cover most major drug classes. We should also pay closer attention to what other rich countries are paying for the same medicines and use that as a reference point. And we should accelerate the approval of generic drugs and biosimilars. These are the cheaper copies that come on the market after a brand name drug's patent run out. Now, I have to be clear about a real trade-off here. If we aggressively negotiate drug prices down, some pharmaceutical research will decline. However, the evidence suggests the reduction would not be huge. Most of the basic science that leads to new drugs is funded by the National Institutes of Health, public money paid by taxpayers, and then privatized when the drug company picks up the discovery. The money drug companies charge above what it costs to make the drug isn't all financing the next breakthrough cancer treatment. A meaningful share is being captured as returns to capital, not as research investment. But the argument is not settled. Serious economists disagree about how much breakthrough innovation depends on the high prices Americans pay. Some of them think aggressive pricing would meaningfully slow real innovation. I'm not going to pretend they are obviously wrong. So we have to weigh two risks against each other. The first is that some important research does not get funded if we negotiate aggressively. The second is that working families in this country are skipping prescriptions and rationing medication because they cannot afford what their doctors are telling them they need. That is not a hypothetical. That is happening right now at scale. We should not be willing to keep paying far more than every other developed country pays, and bankrupting working families in the process to preserve a level of pharmaceutical innovation that may or may not depend on the rents that are being extracted. The trade-off exists. The cost of the status quo does too. The right answer is to negotiate hard, accept some loss of innovation, possibly significant, possibly small. We won't fully know until we do it, and stop forcing Americans to choose between their health and their financial survival. Lever 2. Hospital antitrust and rate discipline. This one is straightforward. We need to start enforcing antitrust law against hospital mergers. We have not done this seriously in 3 decades. The Federal Trade Commission and the Justice Department have allowed far too many American hospitals to consolidate into regional monopolies, and we are all paying the price for it. That has to change. Also, where past hospital mergers have produced clear regional monopolies and divestiture is feasible, force the breakup. Where it isn't, set rates the way Maryland does. Maryland is the one state in the country that has used what's called all-payer rate setting for hospital services. Every insurer, public or private, pays the same rate for the same procedure. It has worked. It has produced lower costs and equivalent quality. We should expand that model. Medicare should also move to what's called site-neutral payment. Right now, if you get the same procedure done in a hospital-owned outpatient clinic, Medicare pays much more than if it were done in an independent clinic, even though it's literally the same procedure with the same outcome. That gap is pure rent. Eliminating it is one of the most clearly justified reforms available. And we should also be breaking up the worst of the vertical integration. The hospital systems that have been buying up doctor practices to charge hospital prices for routine services. Lastly, require real price transparency. Actual negotiated rates, published and comparable. Because you cannot set rates, enforce antitrust, or run site-neutral payment on prices that are hidden. Lever 3. Expand the supply of providers. End the cap on federally funded medical residencies. Train more doctors. Repeal certificate of need laws in the 35 states that still have them. Let providers compete. Expand the scope of practice for nurse practitioners, physician assistants, and pharmacists so they can deliver the routine care they're already trained to handle. Make it dramatically easier for foreign-trained doctors to practice in the United States. We should screen for quality. We shouldn't bar them out of protectionism. Push more routine care into outpatient settings, retail clinics, and telehealth, where costs are lower and access is better. Each of these is a state-by-state fight or a federal regulatory fight. None of them are theoretically complicated. All of them are politically hard because they cross entrenched professional guilds. Lever 4. Reform the prescription drug middlemen. These are the 3 companies that control 80% of the prescription drug middlemen market. They use opaque rate structures and spread pricing, meaning they pay pharmacies one price for a drug and charge insurance companies another, and they take the difference. It is one of the cleanest examples of unjustified rent extraction in the entire economy. Either require full price transparency and pass-through pricing, or eliminate the role entirely. And finally, lever 5, administrative simplification. American healthcare burns a staggering amount of money on administrative overhead. Estimates put it between 15 and 30% of total spending, vastly higher than any peer country. The reason isn't complicated. Every insurer has its own forms, its own rules, its own prior authorization process. Every hospital and every doctor's office runs entire staffs whose job is navigating the paperwork. Claims get denied, appealed, resubmitted. Networks get reshuffled. Patients get billed wrong and have to fight it. None of this is care for anybody. It is pure friction. The fix is standardization. One claims form, one set of prior authorization rules, one credentialing process. Also, tighten limits on what percentage of insurance premiums can be spent on overhead rather than care. This is regulation, not government takeover. The same kind of standard setting the federal government already does in airlines, banking, food safety, and securities. It does not require putting the government in charge of healthcare. It requires putting the government in charge of the rules the industry runs on. This is the largest pool of waste in American healthcare. It is also the hardest to capture because the existing administrative complexity supports millions of jobs. Reform here is slow and politically difficult, but the ceiling on savings is enormous. So those are the 5 levers. 4 of them sort cleanly onto the principal. Drug pricing, hospital antitrust, and prescription middlemen reform hit the parts of healthcare where concentrated players extract rents. Supply expansion hits the parts where competition has been artificially restricted. Another thing, because it's the question everyone asks. What about the insurance companies? The frustration with insurers is real, and it's legitimate. The denials, the prior authorizations, the friction. This program does standardize their claims and authorization processes, and further constrains their overhead. But insurance companies aren't the primary target because they're not where the cost is. Insurance company profit margins are actually tight, typically 3 to 6%, and capped by federal medical loss ratio rules that require 80 to 85% of premiums to go towards actual medical care. The big money in American healthcare isn't insurer profits. It's what insurers pay out to hospitals, drug companies, and middlemen. Break those upstream costs, and premiums come down with them. And if you're wondering how this all actually gets done, a lot of what I just described is federal. Medicare drug negotiation, hospital antitrust, residency caps, drug middlemen regulation, administrative standardization, all federal. The federal government can do most of these things directly through existing authority. But meaningful pieces are at the state level. Scope of practice for nurse practitioners and physician assistants is set state by state. Certificate of need laws live in state legislatures. Medical licensing is state administered. Supply expansion is a state fight. In dozens of capitals, one at a time, against the local medical associations that profit from the restrictions. But the federal levers do more than act directly. They help to change the conditions the state fights happen in. Ultimately, there is no single bill that fixes American healthcare. It is a campaign. And a final note. This program does not solve everything. I should be clear about what it doesn't cover. Medicaid, the program that insures 80 million low-income Americans, and is the largest single expense line crowding out state budgets, is helped by everything in this program, but needs its own dedicated reimbursement reform. Mental health fits the framework, but it has its own specific dynamics that this program doesn't name. Long-term care for the elderly, nursing home care, home health aid care is a separate fight. It requires its own settlement, and the demographic pressure on it is going to be brutal. End-of-life care accounts for a substantial share of Medicare spending. Every direct attempt to reform it dies politically because critics scream about death panels. That requires cultural change, more than policy change, and I'm not going to pretend I have a solution for it. Rural health care is its own problem as well. Antitrust on consolidated systems could actually accelerate rural hospital closures in places where consolidation is the only thing keeping a hospital open at all. Rural health care needs the direct successor to Hill-Burton, the 1946 law that built hospital infrastructure across rural America when private markets wouldn't. That means dedicated federal investment in rural capacity, expanded telehealth, expanded scope of practice for nurse practitioners in underserved areas, and direct federal incentives for clinicians willing to practice in rural America. The federal government helped build rural hospital infrastructure once. It can do it again. Now you're going to want to know the question that I'm saying matters most. How much does this actually save? Before I give you any value, a disclaimer about what numbers mean in healthcare policy. Every cost estimate, every Congressional Budget Office score, every advocacy white paper, every academic projection is based on a model. Models embed assumptions about implementation, about behavior, about second-order effects that nobody can fully predict. They are frequently wrong, sometimes dramatically wrong. The Affordable Care Act was scored to cost more than it actually has. Medicare Part D came in well under its projections. The CBO's track record on healthcare scoring is mixed. What I can tell you with reasonable confidence is the direction and the rough size of what this program would accomplish. I cannot tell you the exact dollar figure, the exact timeline, or exactly how the savings break down across the system. But this is the rough picture. Let's say we get savings in the ballpark of 10 to 20% of total system spending, which is within a reasonable range of available studies. American healthcare spending, system-wide, is over $5.5 trillion a year. So we're talking about savings of over $500 billion to over $1 trillion a year. The high end requires aggressive implementation and the absolute right political conditions. The low end is more realistic. The savings come from several sources with different time horizons. Drug pricing reform delivers the most concentrated savings on the shortest timeline. The government starts negotiating and prices come down. Hospital antitrust and site-neutral payment deliver substantial savings as enforcement compounds. Each block merger, each enforced rate accumulates. Administrative simplification has the largest theoretical ceiling, but depends on how aggressively the system is restructured. There's a huge amount of waste, but capturing it requires significant coordination. Supply expansion is the slowest payoff. Training doctors takes a decade, but it compounds over generations. None of these reforms individually solve the cost crisis. Together, working in combination, they discipline the system. So after hearing this, a logical question to ask would be, why can't we go further? If 10 to 20% is the realistic ceiling, why not push for more? Because greater savings would require moving to a full, single-payer, European-style system, with all the consequences this country has already refused. The remaining gap is the price Americans pay for keeping comprehensive government control out of healthcare. The reform program I've laid out works within that choice. It is important to put 10 to 20% in perspective. While that percentage sounds modest, the impact is massive. Today, the federal government accounts for almost a third of all U.S. healthcare spending. If we achieve system-wide savings on that scale over a decade, we return trillions of dollars to the U.S. Treasury. This is one of the largest fiscal tools available to the American government, and it provides the necessary capital to do significant things. A meaningful reduction in total spending creates the financial flexibility to address the healthcare coverage gap. It also repairs public balance sheets. The savings from this program don't just reduce premiums for working families. They drastically reduce the burden of Medicare, Medicaid, and ACA subsidies for state and federal budgets. That is the difference between Medicare projecting insolvency within a decade and remaining solvent for the rest of the century. And despite the tremendous benefits of yearly savings, a sustained reduction in the rate at which costs grow matters even more. For decades, American healthcare costs have outpaced the broader economy. If this program simply bends that curve, so healthcare costs grow at the same rate as the rest of the economy, instead of faster, the result is generationally consequential. It is the difference between a federal debt trajectory that collapses under demographic pressure and one that stabilizes. Now, a final word on standard of care. Critics of any cost-focused program will ask whether we're sacrificing quality. The empirical answer is no. The hundreds of thousands of preventable deaths in American hospitals every year are not a function of cost discipline. They are a function of fragmented care and weak quality measurement. The reforms actually improve quality because standardization fixes fragmentation, and breaking up regional hospital monopolies restores the competitive pressure that surfaces and punishes poor outcomes. Pressure or monopoly never has to answer to. Now, none of this happens unless somebody fights for it. And the question of who fights for it is the question that determines whether any of this is possible. The losers from real reform are concentrated and powerful. Hospital systems, pharmaceutical companies, insurance companies, the drug middlemen, specialist guilds. They have organized political power. They outspend every other industry on federal lobbying, and they have a clear interest in preserving the system that pays them. The winners are far more numerous but diffuse. Every working family paying premiums, every taxpayer funding Medicare and Medicaid, every employer who can't give a raise because health benefit costs keep rising, every state government with budgets crushed by Medicaid spending. That is the problem. Concentrated interests with money and focus defeat fragmented majorities every single time. If we fight this battle on healthcare alone, the cartel wins. They have too much money and too much congressional protection for a narrow, single-issue fight. The coalition that breaks the healthcare cartel has to be the same coalition that breaks the broader pattern we've been mapping. The same displaced majority paying the price for a polarized, stagnant political system unable to solve our deep structural challenges is the same majority getting crushed by healthcare costs. The issue is just one front. To fix it, we have to assemble a real coalition, conscious of itself across party lines, that can finally assert its political weight to discipline this accumulated dysfunction and turn around this country's current trajectory. That is the framework for America we need to recover. Pragmatic statecraft. It built American capacity before. It can rebuild it again, but only if we organize the majority to fight for it.